Hello, everybody. Hi there. You're very welcome to this session on research communication, a novel approach, where we are looking at how researchers and the public can work together, and by doing so, make that research better quality, make it more relevant, and bring in bigger impact. My name is Claire O'Connell. I am a science communicator, a science journalist, and I have to say it has been wonderful in the last number of years to see how researchers are actively looking to engage with wider audiences, with people whose insights and whose experiences can bring extra richness and extra impact to studies, projects, clinical trials. And that often means talking to people very early in the process of research so that research is designed to be asking the right questions and then involving as many and as big a variety of people as you can in the research itself. So how can that dialogue between researchers and the wider public and patients, not a monologue, a dialogue, how can that positively affect research, and how do we get that dialogue going? Talking about this today, we have four wonderful speakers who we will meet in turn, and each one will give us a short presentation. Then at the end, we're going to have a panel discussion. So we would love to hear from you, the audience. We want you asking questions. So if anything occurs to you while the talks are ongoing or while we're doing the panel discussion, please use the Q&A tab. You'll see it hopefully at the top of your screen. And you can type a question in there anytime, and we'll be able to come back to it during the discussion after we've heard from the presenters. And just before we kick off, I would like to acknowledge all the hard work that has gone into bringing everybody together today. So thank you to the people behind this, the RCSI, Department of Obstetrics and Gynaecology, and the Health Research Board, who are supporting this through their conference and event scheme. So let's kick off with our first speaker, who is Dr. Michelle Flood. Michelle is a pharmacist and a senior lecturer at the School of Pharmacy and Biomolecular Sciences at RCSI. She is RCSI PPI Ignite Network Lead and Academic Lead for PPI and Engaged Research. And Michelle will, maybe not surprisingly, be talking to us about patient and public involvement, or PPI. So thank you, Michelle. Take it away.
Great. Thanks so much, Claire. So I'm delighted to be invited to speak at this event today. It's always lovely to be involved with anything Zara and Eliza are doing, because they're very much leaders in PPI at RCSI. So what I'm going to do is just take you through, I suppose, what PPI is, a little bit about how you might get involved. I'm assuming kind of a starting point for a lot of people, because I know people are at different stages of their journey. So I'll start with what is PPI research. So I say PPI, I suppose, a little bit too quickly because it's something I work a lot in, but what it means is patient and public involvement in research, and it's sometimes abbreviated now to public involvement in research. And what that means is the research is carried out with or by patients or the public, rather than to, about, or for them. And we think about it a little bit more as researchers, and, you know, I do PPI a small part of my role. My main role is a lecturer and researcher at RCSI. You know, years ago, I would have identified a gap in the literature. I would have said, okay, you know, something is a problem. Maybe we need to focus on this. Or maybe slightly better, because I practice as a pharmacist as well. Maybe I might have seen something clinically of interest and said, look, I think there's something that needs to be looked at here. But what we didn't tend to do was ask the real experts, the patients and the public, about what was important to them. And thankfully now, we realise this is a much better way to go about our research, to include patients and the public from the start. So we're much clearer on their needs and priorities, so we can focus our limited time and resources on things that really matter. So it's an active partnership between patients, carers, family members, service users, friends, and members of the public. Think inclusive, so it's designed to include everybody, in a way that helps influence and shape the research. So it's not just kind of little bits around the edges, it's patients having a core and central role in what we're doing and how we do it. So just to kind of break that down a little bit further, particularly people who are doing clinical research, you might say, well, you know what, I use, you know, kind of patient data all the time. Patients are involved, they give me samples or they give me feedback through questionnaires or focus groups. And that's really important, but that's now known as participation. So someone is giving their information to you, the researcher, to make, I suppose, the research progress. You might be familiar as well with engagement. So this is where researchers communicate their findings outwards to the public. So seminars, festivals, newsletters, educational activities. kind of science week events, things like that would traditionally have been sort of information being transmitted out from the university. But I liked what Claire said at the start about dialogue, because involvement is this two-way interaction and dialogue between researchers and patients or members of the public to look at really important things in research. So what are we going to research? What's the gap? What are the questions that we should address? Can we work together on getting funding? I've had patients in the public as co-applicants on numerous funding applications at this stage. So co-applicants and collaborators, and they're working alongside me as a partner. Advisory panels, research plans, materials, dissemination, all that kind of thing. So really involved throughout the whole research cycle. And I suppose what I've described there maybe as a process, but I just want to flag that, yes, that's a definition, but it's actually an ethos or a way of doing research. It's not simply just, oh, these are steps that you follow. And at the network level, we've developed, led by Trinity, a set of values that we ask people who are doing PPI to follow. So respect, transparency, empowerment, power sharing, trust, collaboration, partnership, flexibility, and equity and inclusion. And it's not always easy because, you know, you're adding another partner to your team, somebody who maybe has a different perspective, but it's really important to work with those values to make sure that everybody feels included and they are valued as an equal member. You do need good communication skills, facilitation skills, and collaboration skills, but that's any researcher. You're not going to get too far if you don't have those. And it's really important to tailor your approach to patient and public involvement. It's not a one-size-fits-all by any stretch of the imagination, but you need to think about what resources do I have, you know, that's both in terms of abilities, but also financials, that I'll talk about a little bit more in a minute. Folks might be familiar with the Science Foundation Ireland kind of version of patient and public involvement. They speak about engaged research. So you might hear that terminology used by funders like Wellcome or the Science Foundation Ireland. But what again, if you see, they're talking about the same things at this sort of middle part of the onion, which is where we want to be. So patients and the public informing the research program, helping us, you know, engage with policymakers, and then working through shared partnership and decision making. So don't be alarmed if you see this model instead. It's very much the same, with the kind of more engagement stuff on the outside. You know, all very important, but we're trying to work towards is this more partnership model. So why do we do it? Why do we take the steps to do PPI and research? There's lots of evidence, and this research evidence suggests many benefits, particularly in clinical trials, which is interesting. Including improved quality and relevance, design, outcomes, impact, and you know, there's lots of benefits, but again, there are some challenges which I'll come back to in a minute. But our research has improved in terms of quality and relevance because you've brought another expert into the team. So you're bringing somebody who has a real expertise in the particular condition. They will know more than you could ever know about what it's like to live or to experience a particular disease or condition, or to live with somebody who experiences it. So having that information is invaluable. Reducing research waste is something we're all trying to do. So a lot of trials, for example, will fail to recruit to target. And when you look back and you kind of say, why did that happen? You know, if you're asking patients to come in, you know, every week or every month, or, you know, for something invasive or something painful. And if you talk to patients about that, the planning stage, and say, you know, is this something that people could do? You know, making sure that you reduce as many barriers as you can to participation at the start through involving patients will help reduce the waste associated, particularly with clinical trials, given the focus of today. Really important to make sure their outcomes and impact are improved through actually doing things that focus on patient needs. So a lot of people talk now about implementation science, but, you know, when we do patient public involvement, we reduce that implementation gap because we know what we're doing is going to be important and relevant at the end. And you're not going to have to try to sell it or try to make it, you know, kind of something that people want when actually they've told you up front. So I always think about, you know, I have a limited lifespan as a researcher, you know, probably a limited number of grants in me, you know, so I want to spend my time doing things that people actually care about, because otherwise, you know, papers are fine, but, you know, we are still working in healthcare to try to help patients. And there's also lots of benefits for researchers and PPI contributors. Particularly, I work a lot with preclinical researchers who find PPI to be a great source of motivation when you're in the lab, just, you know, working away. You know, it gives you a sense of people at the end. And also the PPI contributors themselves, they feel heard, they have some influence and have an improved relationship with their illness. In some cases, has been reported as well. Now, just to remind you and to remind everybody that we're not all the same, and it was Neurodiversity Week last week, so it's kind of timely just to remember that patient and public involvement can be particularly difficult for certain people, or people might find it a particular challenge. So do take into account, you know, the needs of your team members, and make sure that you've had a conversation about how to work best together, particularly if you are working with researchers or PPI contributors who are neurodiverse or neurocurious. And we had an event as part of the PPI Festival last week where neurodivergent researchers came together and helped us figure out what recommendations to give people. And it was illustrated by a fantastic graphic artist, Ruth Graham, not by me. And then, so how do we incorporate PPI into our research? So you'll often see this presented as a research cycle, which is a very nice circle, but I don't know about anyone else's research, but mine certainly doesn't go in a nice circle. It, you know, loops back on itself and things change over time. So I prefer to present it as a squiggle. So we can involve patients and the public from the very start, identifying and prioritizing research, so helping us to pick what it is we're trying to do. As I said, we can help with design, clarifying research questions that matter, methodology that's feasible and possible for patients to engage with, particularly in clinical trials, recruitment strategies. So how will you find people? Where will we get access to let people know this research is happening? All those types of things are very important. And we worked with patients on analysing and interpreting data, and it's really, really interesting to see their lens. So the way a result might seem to a researcher, you might say, okay, this is kind of unusual, but a patient can very quickly say to you, you know, this is the reason why I'm not, that, you know, that could be the case. And a good example is I work with seriously injured rugby players through a project with the IRFU Charitable Trust and the Amber Centre. And our findings came back and people were kind of a little bit not too, you know, we were trying to figure out why were people maybe not as interested in PPI as they might be. And we kind of said, oh, right, you know, maybe they're not too busy or whatever. But one of the seriously injured rugby players on the team said, actually, do you know what? It's because the time, you know, from the time of injury, we were told to accept and adapt. We're told to accept what it is. So research is actually opening up this different angle that we've sort of been advised to kind of stay away from. We've been told we are what, you know, and we're now talking about spinal cord injury repair. So that was really interesting. And I would never have known to think of that. Never, like, would never have come into our minds. Undertaking and management of research, so collecting data, carrying out interviews. You can train participant PPI contributors to do this. We've lots of patients on steering groups, and it's really wonderful to hear their perspectives. And then really importantly, talking about communication today, helping disseminate the information, helping explain it really well, helping call out the things that are important to the public rather than necessarily to the researchers. And we've co-written lots of different papers and, you know, kind of informal pieces with patients. And it's just a much better outcome when you do it that way. So how do you get involved? So if it's a researcher or a clinician looking to get involved, kind of say reach out to your PPI Ignite Network office if you have one. So there's 7 universities that have offices I'll talk about in a minute, but somebody there. Otherwise, the offices of research or innovation will have some information on it. We do lots of training and education at institutional, national levels, and I'll show you how to find that just in one moment. Charities and patient organisations often have groups or, you know, run sessions or seminars that you can attend, and find a colleague who's already doing PPI and doing it well. That's how a lot of people learn, is just saying, look, I'd love to learn a little bit more. Can I observe what you're doing? Can you tell me a little bit more? Can we have a coffee and a chat? And for patients, the PPI Opportunities Notice Board, I'll show you in a moment, is wonderful. Social media is where a lot of researchers will post their opportunities. Charities and patient organisations such as ICOSI have a dedicated training programme that link, then try and link people into opportunities as well. And then the university websites will all have information. So if there are any patients in the public, definitely, you know, people are always looking for your expertise and insight. So just try to find where they're looking for. The PPI Opportunities Notice Board is really wonderful. It's run by the National Office of the PPI Ignite Network, and it has a range of opportunities available. For researchers, you can post your opportunity there if your university is part of the network, and for patients, you can find information about opportunities there, including what funding is available, how will you be reimbursed for your time, what's the time commitment, all those types of things are there. And you'll see some familiar faces at this event, but every year as well, there's the annual PPI Ignite Festival. That happens in October. And Elisa and Zara are brilliant, always running really good events. And it's once a year, a month dedicated to celebrating and promoting patient and public involvement. There's a huge range of events, training, celebration events, networking events, and they're generally run by the universities, but also by patient organisations and charities. And it's a really great way to learn more about PPI. And the Rotunda had 2 events last year, which was really great. And where can you find out more? So just to wrap up, I mentioned at the start, RCSI is part of the PPI Ignite network. It's one of 7 universities that have joined a €5 million network funded by the HRB with co-funding from the universities. And they have people like me, so an academic lead, and then a program manager in place locally to help. If you're a little bit more advanced and if you're kind of very familiar with this, there are also many academic journals, for example, Research Involvement and Engagement and Health Expectations that publish patient and public involvement, so you'll be able to read about it there. But this PPI Ignite network is a great place to start because there's loads of case studies and different things you can read about there. And that's it. I just want to say thank you so much. And also just to highlight anybody at RCSI, myself or Neve, who's the RCSI Patient Public Involvement Programme Manager, can be contacted at ppi@rcsi.ie, or if anybody has any questions at all, be delighted. So thank you.
Thank you. Thank you so much, Michelle. And please do put your questions for Michelle or for any of our speakers into the Q&A panel. You know, it's been wonderful, Michelle, to see how the PPI Ignite network has grown and consolidated and, you know, enabled by the HRB, it must be said. And they have been in turn enabling PPI in health research. I will come back to a couple of points you made there, I think, in the discussions. Really interesting talk. You crammed a lot of contextual and very practical information in there, so thank you for that. I really like how you say to look at PPI as an ethos, because it can feel a little bit overwhelming, I think, when you're new to it. So to just think this is a way of approaching things. Brilliant. Thank you. So our next speaker is Professor Fionnuala Breathnach, and Fionnuala is a consultant in obstetrics and gynaecology and an associate professor of obstetrics and gynaecology at RCSI, and she is the principal investigator, or the PI, of the Ireland trial, and she's going to tell us about that research into diabetes in pregnancy. So Fionnuala, you can share your slides there. Brilliant.
Thank you, Claire. You can hear me okay? Great, super. So thank you very much for inviting me to speak today, and this is a super forum. As you know, the group here at RCSI Rotunda is very heavily invested in public involvement, and we have a research agenda that goes back over a decade now relating specifically to diabetes in pregnancy. Now, it is a key interest, clinical interest of my own, as well as being a research interest that has been born, I suppose, out of the observation that women with diabetes in pregnancy represent the highest risk obstetric patient population that we care for. And there is obviously in recent years a mushrooming of the population of pregnant women who get the gestational diabetes label during their pregnancy. And there unfortunately is a lot of scope for women with gestational diabetes to quite wrongly, I think, be labelled as having diabetes in pregnancy in the same way that, or be considered in the same breath as women with type 1 or type 2 diabetes. And we have heard repeatedly from patients that this labelling of everybody under the same umbrella is actually damaging to the vast majority of women that we see with gestational diabetes. So one of the first things that we have tried to address in this research and clinical field is to separate out gestational diabetes from type 1 and type 2 diabetes to the betterment of all diabetes groups. And the reason that I say that is that when I started the diabetes clinic here took over the diabetes clinic in 2010, all women with diabetes in pregnancy were seen in the same clinic. And so we had women who are that extraordinarily high risk group with type 1 and type 2 diabetes, who were sitting alongside women with very minor aberrations in their sugar levels during pregnancy, and who were just demonstrating what is normal and physiologic for pregnancy, but with slightly higher sugar levels that needed to modify their diet to correct them, and that those women were all being seen and offered kind of the same model of care. And it resulted, we believe, in a lot of negativity from patients, and certainly that's the feedback that we were getting, was that patients were saying, please don't label me as having diabetes. And so we have separated out these conditions in response to feedback that we got from patients in a number of steering groups that we ran with patients, and Elisa is going to give an overview of the sort of breakfast club initiative that we set out. And I think that that's been very successful and has been the key message that we've got from women with diabetes over the years. So I'm just going to take you through an overview of different projects that we've taken on in this field, addressing both the needs of women with pre-pregnancy diabetes and separately those with gestational diabetes, and explaining the difference. Now, when you look back 50 years ago, the Rotunda was actually almost as busy as it is today. So today the Rotunda is the busiest maternity hospital in Europe. We have about 8,500 deliveries, and 50 years ago we had 7,500. And we have this gem of an annual clinical report that is printed every year, that goes back about 150 years, and these are stored in a refrigerated environment in our library at the hospital. And it's possible to take these out and read them, and they make for fascinating reading. And we've shared some of this information with patients, and they find it absolutely fascinating, particularly women with type 1 and type 2 diabetes. And we know from the 1970 report, for example, that all of 3 women in the hospital had diabetes. And of those 3, 1 had a stillbirth, 1 had a neonatal death, and there was 1 survivor who was described as having made excellent progress after the pregnant woman was hospitalised for 13 weeks during her pregnancy. So now we would obviously be appalled at seeing, results like this, a 30%, 33% survival rate for diabetes in pregnancy nowadays. However, the landscape was just completely different in those days. And nowadays, this is what we're seeing, is that only 4% of our diabetes in pregnancy population have type 1 or type 2 diabetes. And then we have an additional 1,300, and in fact last year it was 1,600 women with gestational diabetes, which represents 17% of the obstetric population. Now, part of the reason for this is that the thresholds for diagnosing gestational diabetes have been changed over the last number of years in response to large-scale clinical trials, international trials, that have lowered the threshold for diagnosing gestational diabetes. And so we don't screen everybody, but we screen about 1/5 of the population who have risk factors, and that results in a huge number of people being diagnosed with gestational diabetes, and those women will generally, the vast majority of them, just need some dietary modification during pregnancy. So it's unfair to consider that they have true diabetes, because the vast majority of them will revert to normal post-pregnancy. But probably the most significant consequence of identifying gestational diabetes is that we then have identified somebody who's got an up to 50% risk of developing type 2 diabetes decades later, so later in life. And therefore, these women need a diabetes screen every year. But how do we manage such a large volume of patients who are all considered to have diabetes in pregnancy? And the approach that we have taken is to actually, in response to feedback that we've had from patients, is to actually not overly medicalize the condition. So the risk factors associated, or the potential consequences of diabetes, you can see here are 2 very different landscapes. So for pre-gestational, which would be type 1 or type 2 diabetes, this long list of basically anything on the menu that you could list as an obstetric risk is a risk factor for that is to which patients with type 1 and type 2 diabetes are potentially exposed. Whereas with gestational diabetes, those patients can have bigger babies. The association with preeclampsia is kind of under question and increasingly is being refuted now. And like I said, the most significant issue is type 2 diabetes later in life. And so we will sometimes say to patients that actually the diagnosis of gestational diabetes could be considered if you were somebody who takes a glass half full or sunny side up approach to everything, is to consider gestational diabetes diagnosis to be the gift of a lifetime, in, you know, a wake-up call for lifestyle modification that can reduce your risk of type 2 diabetes in the longer term. Now, over the course of the last 50 years, and I gave a talk in Sydney last year, and so I thought it was apt to maybe illustrate that, as the length of time that the Sydney Opera House has been in existence, is that over the course of that time, advances in perinatal care and neonatal care have been enormous. Okay, so we started doing ultrasound around about the 1970s, and then our ability to learn a huge amount about fetal physiology and how the circulation works and interacts between the fetus and the mother. All of that has advanced enormously over the last 5 decades. And the introduction of surfactant means that a baby's lungs will work much better now at an extremely early gestation than they would have done decades ago. And so now the limit of viability, the gestational age at which a baby can potentially survive, is now just about 23 weeks, in a way that it would have been about 28 weeks in the 1970s. So enormous advances have happened. But how does the landscape look then so for patients with diabetes? Well, disappointingly, risk for patients with type 1 and type 2 diabetes, risks of stillbirth, of adverse perinatal outcome are still extremely high. And so this observation led to a declaration, a sort of a consensus declaration in 1989, that women with diabetes should achieve pregnancy outcomes that approximate those of women without diabetes, if sufficient effort is afforded to looking after these pregnancies. And disappointingly, now 30 years later, have these aspirations been achieved? And we would say disappointingly, sadly, no. Congenital malformation rates are still twice as high as in the non-diabetes population. Perinatal mortality is almost 4 times higher. Preterm delivery is 4 times higher, and large for gestational age is 4 times higher than the non-diabetes population. And these are, you know, the key risks that we worry about. We worry about high sugars and how they, in the first trimester, affect the developing embryo in terms of causing malformations, hypertensive disorders that will often lead to preterm birth, and the placenta, how the placenta affects virtually every outcome of pregnancy, and then macrosomia and what that means for the difficulty of delivery. Preeclampsia, as illustrated here in Downton Abbey, in its most extreme form, eclamptic seizures, is still one of the key risks that we worry about with diabetes, but the absolute risk of that is low. So in the general population, in a first pregnancy, would be 2 or 4%, but it's still, you know, 3 or 4 times higher in women with type 1 or type 2 diabetes. And the importance is of recognizing it and acting very swiftly on what can be a serious condition. Now, when it comes to public involvement with complying with treatments that we recommend, and so we've explored for the Ireland study the idea of aspirin for improving pregnancy outcome in women with type 1 and type 2 diabetes. high-risk pregnancy is a term that is bandied about a lot, and it's a term to which I'm personally allergic because it is a little bit meaningless. High-risk pregnancy, there's a long laundry list of conditions that are considered to render a pregnancy high risk, and they could be advanced maternal age or fertility treatment or twin pregnancy or things that really have nothing in common. An aspirin is being used to improve how the placenta works for all of these conditions in a quite an indiscriminate way, in such a way that we would take the approach of considering, well, this is a bit like if all you have is a hammer, everything looks like a nail. But these groups, in fact, have generally very little in common. And so the only issue that aspirin treatment is intended to address is how well the placenta works. Now, it's for this reason, and the reason that and the rationale is that aspirin is believed to improve how the placenta functions and the circulation within the placenta, that it is considered that aspirin may benefit all groups that are considered to have maybe a poorly functioning placenta. However, we know that from a compliance perspective, patients are most likely, and we've heard this back from patients, is that they're most likely to comply with the treatment if they believe that they will personally benefit from it, and much less likely to comply with kind of blanket advice that's dispensed without any clear evidence that that treatment is going to be beneficial specifically for them. And so aspirin has been investigated in lots and lots of studies for the improvement of pregnancy outcome. But women with diabetes typically are excluded and have been excluded from all of these studies. And why? Because women with diabetes are just too complicated. And so we would feel very strongly that diabetes care in pregnancy has actually not evolved enormously over the last number of decades. And yet, observations of improvement related to improvement in other groups are then just being imported into the diabetes population without any clear evidence that, for example, aspirin is in any way helpful. So this is just an example of a number of studies that have been done that have demonstrated an improvement in pregnancy outcome and a reduced incidence of preeclampsia where aspirin is used in pregnancy at really quite varying doses. But importantly, when you look at pre-gestational diabetes, the proportion of participants that have diabetes in these studies is really very small. And for the most part, actually, in most of the studies, women with diabetes have been excluded. And for those studies that did include women with diabetes, the sub-analysis of that group demonstrated no benefit. And so that's why we designed the Ireland study, was to look to see, well, this is the population that right now we care about, is patients with type 1 and type 2 diabetes. Should they all be on a low dose of aspirin, 150 milligrams, started early in the pregnancy to influence pregnancy outcome? And if so, all women with diabetes should be on aspirin. And if not, then they should not. Women with diabetes have a complicated enough time. Their pregnancy is sufficiently medicalized that actually we shouldn't be treating them with or providing any intervention that actually is not of any proven benefit. Now, I'm going to zip quickly through. We recruited in 6 centres across Ireland, and I just want to go really quickly through this because I'm aware that I'm likely running out of time. And what did we demonstrate? Apologies for the lack of a title on this slide. That's an error on my part. But so we didn't demonstrate a difference in the outcomes that we were expecting that aspirin would influence. So we were expecting, from our knowledge of how aspirin affects other pregnancies and other at-risk groups, that we would see potentially an improvement in the placenta in such a way that reduced the incidence of preeclampsia, reduced the incidence of stillbirth, reduced the incidence of preterm birth or small babies. And in fact, what we demonstrated is that those outcomes were no different between aspirin and the placebo group, but that in fact diabetes control was improved across pregnancy in women who were taking aspirin. to the extent that actually, and we expect insulin doses to increase across gestation for all women with type 1 and type 2 diabetes, and that women who were on aspirin needed 83% more insulin across their pregnancy, whereas those who were not taking aspirin required 181% of an increase in their aspirin dosing. So this was very significant. And insulin requirements were also demonstrated to impact adverse perinatal outcome. Okay, so women with better control have better pregnancy outcomes, and this is what we expected. But we didn't expect to see the very stark effect that we have demonstrated of aspirin and diabetes control. And we have published that paper in recent weeks in the American Journal. I just want to move quickly onto just gestational diabetes finally, because this is really important. And as I said, Elisa is going to talk about the Breakfast Club initiative, but we were very keen to ensure that patients with gestational diabetes had a voice in designing a new model of care for how to look after these pregnancies. I've described already how extraordinarily high risk the type 1 and type 2 diabetes patient group is. And the risk is that if you bundle them all of these diagnoses in the same clinic and discuss them all in the same breath, then potentially you risk diluting out the very intensive care that is required of type 1 and type 2 diabetes, and at the same time over-medicalize women with gestational diabetes. So we were very much focused on designing a self-management program for women with gestational diabetes, so that together with a midwifery-led group and with the support of dietitian input, that women could continue to attend their own chosen model of obstetric care or midwifery-led care, but self-managing their diabetes with app assistance that provided feedback for them. And so we designed a smartphone application that encouraged self-monitoring, recording of dietary intake and exercise, and facilitating personalised feedback. And now we've lots of results from this study, but just to demonstrate that those who used our app-assisted care in comparison to a historical cohort had a lower number of visits to the hospital, a lower number of needing to be referred to the dietitian, and a shorter hospital stay, in addition to incurring significant cost savings both for the patient and indeed for the hospital. Patient satisfaction, I don't have patient satisfaction slide, but it almost goes without saying that patients are enormously grateful for not being referred to so many hospital visits, when in fact they can take ownership and control over their own gestational diabetes. And we're seeing improved perinatal outcomes across the board in this group, which is very satisfying and gratifying for us, but for the most part has been driven by the messaging that we get from patients in our steering group forums that we run periodically, and that's been enormously informative for the direction that our diabetes-related research has taken here at the Rotunda.
Thank you so much, Fionnuala. That was another brilliant presentation. We will have time for questions afterwards in the panel. I'm very keen to hear more about the way you actively listen to patients. It sounds like this is something you've been doing for quite a while, and we can learn a lot from you and the channels you create. You mentioned the app, the steering group, that kind of thing, and you know, it might be good to hear more about that in the discussion. Thank you. So our next speaker, and Fionnuala has already mentioned the Breakfast Club, which, you know, if you're my age, it's a film starring Molly Ringwald. But I think Elisa Belmonte is going to tell us something else. Elisa is a communications manager at the RCSI Department of Obstetrics and Gynaecology, and she worked on the Breakfast Club comic, which is an ingenious graphic novel project making diabetes in pregnancy both relatable and fun. So Elisa, take it away.
Thank you, Claire. Yes, so I'm Elisa Belmonte, and I work in the RCSI Obstetrics and Gynaecology department, and I manage all the communication projects here. So I'm going to give you a little overview of who we are. So yeah, I work for the Department of Obstetrics and Gynaecology, and the department has been working on communication and outreach projects since 2016. It's a very big focus of our department to share findings and to communicate these findings with the local community and with the general public to promote the impact that the research can have on everyday life. These are some of the projects that the department created since 2016. So deepening the patient and public engagement in research is one of our core values and objective. You can see since 2016 we worked on the first one is Curious Parents, which was a series of short animated films that highlighted maternal and newborn health issues. We worked on an art exhibition, Create, the Art of Pregnancy and Beyond, to highlight common pregnancy and newborn health issues. Real Talk with Real Moms is an expert advised and mom approved 10 episode podcast series. And then more recently, we focused on debunking the myths, the science behind our sexual health, which is a series of interactive 2-hour workshops to provide clear and reliable information in relation to sexual health to TY students all around the country here in Ireland. But today, I am gonna focus on this lovely project, the Breakfast Club comic, which is the story of diabetes in pregnancy in Ireland. This project explored real stories of women who have gone through the pregnancy journey with diabetes through the medium of a graphic novel. And the comic was illustrated by the super talented artist Fiona Carey. The project was associated with the Ireland study, which Prof Breathnach mentioned. So we received funding from the Health Research Board through the Knowledge Exchange and Dissemination Scheme to complement this clinical trial that was studying diabetes in pregnancy in order to disseminate the information and engage the public with this area of research. We wanted to inform and educate the public and engage with the pregnant women who were going through this journey together. So our aims mainly were raise awareness of the different types of diabetes and how they can impact the pregnancy, and then highlight how different women navigated their personal journey. And I wanted this project to be relatable both for women who were going through the same journey, but also for the general public and to raise awareness among the general public about this topic. It's a very common disease, but it's still associated with a lot of stigma, and we felt there was a need to kind of open up the conversation there. So how did we do that? We launched an open call to attract women interested in sharing their experiences with us. We were delighted that more than 30 women got in touch because basically we were asking them to share personal experiences of a time that's quite sensitive for them. So we were delighted to see this response. We carried out 15 patient interviews, and from these 15 interviews, we created 18 stories that the artist Fiona Carey illustrated. And then we published one story each week on a dedicated Instagram account and on our website. And after that, we were delighted to see the response we received, and so we decided to also publish a physical copy of the comic. So you can see some of the pages. Why a comic? Well, firstly, the medium of comic makes the topic less intense. it gives you an immediate, accessible, and captivating kind of way of dealing with this topic. It's more accessible and it transcends the language. So even though there may be some patients that don't speak English, is not their main language, so they may not engage with a written publication. The use of images can convey emotion much better than just a plain text. And also it gave patients the opportunity to engage with this with the comic at their own pace. So whether they were in a waiting room or whether they were breastfeeding at home, they could just connect and disconnect with the comic at their own pace. Also, the project manager at the time was really into comics, and so we really tried to kind of have this bring our own interest into the workspace, because I think it's a very good way to kind of brainstorm new ideas. The topics that came up from the interviews were very varied. They varied from the difficulties of adjusting their lifestyle as a result of new diagnosis, emotional and psychological aspect of the diagnosis, and as I mentioned, the stigma associated with, for example, the injection, and also the guilt of having diabetes, that guilt of harming your own baby, but also the guilt of having to focus on your own health, when you're much rather focus on your baby's health. These were some of the topics, the psychological aspects, IVF and diabetes, family support, miscarriage. A lot of themes kept coming up during the interviews. When we then created the physical copy, we realized the value of all these stories. So we wanted both to engage with people who may be aware what diabetes is, what gestational diabetes is, but also we wanted to expand the conversation towards people who may not know. So in the publication, we also added glossary pages where if a person doesn't know what, for example, maturity onset diabetes of the young is, can have a quick read of what that is. And also another thing that kept popping up during the interviews were pieces of advice that women were giving to themselves, but also to other women who may find themselves in the same kind of journey. And so we kind of summarized all the advice in dedicated pages so that people could go back and kind of have a nice read through all the advice. Then when we had the publication ready, we made sure to reach all the maternity units around the country. We were delighted with all the requests we received to have the actual copies of the Breakfast Club. I make personally a point every week to share, to bring around the copies to the hospital myself, because I think it's such a nice read in the waiting areas. And then we were delighted to read the feedback from the women who participated in this project. All the women underlined the importance of the Breakfast Club comic in giving them a voice, a way to discuss and analyze a period of their life that was full of apprehensions, joy, but also frustration. And so it created a virtual non-judgmental space where they could experience where they could meet and share their experience. So it helped them process feelings that were still associated with their own personal experience. It made them feel listened and valued from the department, for example. And then they also highlighted how it helped their family and their friends to understand more what they have been through, because maybe sometimes that wasn't the case during the actual journey. And these are some of the feedback we received from the women who were interviewed. This one in particular is very dear because this is a patient with maturity and onset diabetes of the young, and she was highlighting the fact that she never met someone else with the same type of diabetes, and through the Breakfast Club comics, she met another mom, and so they made this connection thanks to the project. It made this mom feel really positive about the future of diabetic care in Ireland. And they were also highlighting how they enjoyed talking about the experience whenever they can. It's almost like a little bit of therapy. Finally, I really want to thank the team. I started as a student participating in the project, and then this was my first actual job. So I feel incredibly lucky to have had the opportunity to work with this amazing team that genuinely cared about the communication side of research. Their sensitivity, their dedication made all the difference. Fiona, the artist Fiona Carey, her work on this project was full of kindness and compassion. We were able to tell these women's stories in the right way thanks to her. So I would like to take a moment to thank the whole team that participated in this amazing project. And then I will leave you with where to find the Breakfast Club. So if you are a patient at the Rotunda Hospital, you'll find them in all the waiting rooms and hopefully all around the country. But we also published it online on Instagram. We have a dedicated page on Instagram, the Breakfast Club comic. And we have the actual comic online, so you can flick through on your iPad or your phone. And I'll make sure to pop the links in the chat box so people can also click. Thanks.
Thank you, Elisa. That's absolutely brilliant. What a gorgeous project. And I can hear, even when you're talking about it, how much it means to you. And we can see how much it has meant to the people who took part in it as well. I also like the fact that you can disseminate it in different ways. It's not only a print, you can also put it on Instagram. Did I see a giant sort of a giant printout of it, nearly the size of the door as well? It's lovely. It's lovely. And I might come back to you on that thing you mentioned about using your own sort of interests even outside work to bring in and see, can you make project, can you engage with more people by doing that? Thank you. So our final speaker is Dr. Kate Gajewska. Kate is the clinical manager for advocacy and research in Diabetes Ireland. She lives with type 1 diabetes. She's a researcher, a diabetes educator, a psychologist, and a patient advocate. So Kate, you wear many hats. I'm looking forward to hearing your presentation now. Thank you.
Exactly. Thank you very much for introduction. Can you please confirm that you could see my screen? Yes? Okay, perfect. So first of all, thank you very much for inviting me to speak at this event. I think it's really, really extremely important to focus on this group of people. So women with diabetes, whether it's gestational diabetes or pregestational diabetes. And thank you very much, Claire, for introducing me. I'll just highlight a few aspects of my role in my life, because I have type 1 diabetes myself. I was diagnosed in 1987. So I'm a patient, and we're talking about patients here. I use all the technology available, automated insulin delivery systems. I'm a patient advocate for years, and I'm a lucky mom of a beautiful 7-year-old Hannah. So I have this experience as a pregnant woman with pregestational diabetes, which I also share during my slides here. But as a background, I'm a psychologist, and I work in a psychology space, and I always worked in diabetes and mental health. I'm also a researcher, and I conducted a PhD on accessing diabetes technology in Ireland. I'm a healthcare professional. I'm an active member of many professional bodies, and now I'm really lucky to work with Diabetes Ireland as a clinical manager for advocacy and research, because here I can really utilize all my expertise from all very different angles. So these slides will be a bit personal, but there will be also, of course, from the professional point of view. So just to start with diabetes. So the burden of diabetes in Ireland is actually huge. It's one of the most burdensome chronic conditions, and cardiovascular disease and diabetes are among the leading causes of death worldwide. We estimate that there's approximately 300,000 people living with diabetes in Ireland, but because we have no diabetes diabetes registry. This is just an estimate. 1 in 3 people over 75 have either cardiovascular disease or diabetes, and it is the most prevalent chronic condition in people aged between 45 and 75 years in Ireland. So, and to mention, type 1 diabetes is not that prevalent, but this is the most prevalent, one of the most prevalent conditions in children, in pediatric population, and up to 7,500 women a year develop gestational diabetes in Ireland. And I think, as Fionnuala mentioned, it's approximately 17% of pregnancies are affected by gestational diabetes. And as Fionnuala mentioned earlier, women with gestational diabetes are then at a lot higher risk of developing type 2 diabetes. So just to mention, when it comes to modeling, type 2 diabetes is growing, and in 10 years, the numbers of people living with diabetes in Ireland will probably double, according to many research. So what is diabetes? Diabetes is a big thing, and I think it was very important what Fionnuala said about labeling, because there are very different types of diabetes, and they have very different types of causes, and experiencing living with diabetes is different when you have different type of diabetes. But overarching cause of diabetes is hyperglycemia. So this is the condition in which the body does not properly process food for use as energy. And this is very, very vague definition, of course. So when it comes to living with diabetes, and of course, you have gestational diabetes, where you have interventions that are more focused on lifestyle. Then you have type 2 diabetes, where you also have lifestyle interventions. You have also lots of medicines to take. You might also need insulin, but with type 1 diabetes, you have no insulin at all, and you have to be your own pancreas. So any person living with diabetes needs to find a balance between managing insulin dosing or medicine dosing or your lifestyle intervention dosing with food, with diet, with everything, and it's 24/7, so it is burdensome. So the natural state of any person living with diabetes is hyperglycemia. Hyperglycemia has its symptoms. You're thirsty, you need to go to the toilet often, you have blurred vision, you have no energy, you're irritable, nervous, you have dry mouth. And if you have type 1 diabetes and you have no insulin at all, and you have to replace it via injections or insulin pump, you are also at high risk of diabetes ketoacidosis and then potentially diabetic coma. So the treatment means that you have to kind of manage this insulin replacement, or you have to make your body working better with insulin that is already being produced by a pancreas. And then if you use your medicines or if you use your interventions, you're also at a higher risk of hypoglycemia, and especially people who have to inject insulin. The risk of hypo is a really daily struggle, and hypos are the worst. You feel really terrible, you are fatigued, you have no energy, you're really weak, you're shaky, irritable, you're sweating, you feel extremely hungry. You can eat the whole fridge, everything that is in the fridge, just to tackle this awful feeling. You can't think properly, your brain is affected, and of course you are at risk of severe hypoglycemia, and I'm talking about people with type 1 diabetes mainly. So what you have to do, you have to increase your glucose values, ideally in a quick way, eating glucose or any sweet drink. But this is just a clear explanation, hopefully, how it works with food and different medicines and insulin. But actually, there are 42 factors that affect blood glucose levels, and so there is a lot more. So it's not only about estimating the correct dose or adapting your insulin values. There's so many other things that affect your final glucose values, starting from carbohydrates and food and fats and proteins, caffeine, whether you drink alcohol or not, medication, different types of medication. Steroids are awful for diabetes. The levels of activity, whether it's a light exercise, whether it's high intensity exercise, because some exercise can increase your glucose values and not reduce it. Biological aspects, so too little sleep, stress and illness, hypoglycemia, and one of the most significant biological factors is probably pregnancy, because it changes a lot when it comes to glucose values when you're pregnant. Then you have environmental aspects, different behaviors, decisions. So there's a lot that has to be taken into account. And I just always like to highlight that the only difference between medicine and poison is in the dose. So we have to take insulin every day. We have to take different medicines every day. But even one insulin unit more than required can cause you feeling unwell. It can cause you having low blood sugar levels and may cause your life at risk in a long-term scenario. So there's absolutely no surprise that mental health and diabetes are working together very often. There is a huge prevalence and there's a huge issue associated with diabetes distress in people. And diabetes distress is an emotional state where people experience feelings such stress, guilt, denial, which arrives from living with diabetes and the burden of self-management, because the self-management is actually hard, and diabetes distress can also be linked to worse health outcomes. And we know that in people with type 1 diabetes and in people with type 2 diabetes, the prevalence of depression, anxiety, any other mental health disorders is a lot higher than in population who is happy to live without diabetes. And then there is also diabetes distress likely in women with gestational diabetes. And according to one study, I think it was conducted in the Netherlands, even 1/3 of women with gestational diabetes were experiencing high levels of diabetes distress. And then those women who had diabetes distress, there was observed association between both diabetes distress and adverse pregnancy outcomes. So mental health, diabetes distress, and the struggle associated with diabetes management really matters when it comes to pregnancy and its outcomes. So I tried to find some evidence and research, and of course there's lots of research related to the fact that diabetes and pregnancy can be a tough moment for people. And that's the study on women with gestational diabetes. And what women with gestational diabetes usually were highlighting as a big issue in their way of living with gestational diabetes is psychological distress. Of course, they felt overwhelmed, they felt lonely, they felt isolated, they were worrying a lot because it's a big information, it's a big thing. You don't have this healthy pregnancy. You have to do your really hard job to not only work for your body, but for the body that you develop inside you. So it's a really, really big thing. Many aspects, many people mentioned the stigma associated with gestational diabetes. It is a big topic because people usually think, oh, you did it to yourself. You blame yourself as well for any adverse outcomes, or if your sugar levels are too high, you always self-blame. And that's the case across the whole population of women with diabetes. And that's why it makes it so burdensome as well. So when it comes to type 1 diabetes, what are the childbearing experiences? There are international reviews. So there are 5 themes that usually appeared when it comes to type 1 diabetes. So glycemic control absolutely dominates the childbearing journey, and this is the experience of any woman with pre-diabetes. There is huge emphasis on risk, and I think Fionnuala mentioned that how many risks are associated with that. It raises huge anxiety among the whole population. It's really tough to live and be pregnant with this kind of information that whatever you do, you still are at so high risk, and not only about yourself but about your child. The importance of social and peer support, that's, I think it's crucial. And Elisa mentioned that as part of the comic book project, I think that was probably the best outcome, that it was that women could have met somebody with a similar experience. They could have chatted about their experiences, share their stories, and I think peer support is absolutely crucial in this moment. And then care organization systems, communication, impact of technology on the childbearing experience. This is really a lot. And I think what was the important finding from this review was that based on lived experiences, women with type 1 diabetes value being treated as partners in their care by healthcare professionals, providing medical and midwifery services. And I think coming back to research and organizing research and including women with pregnant women with diabetes in research is the is the example of such a partnership as well. And then when it comes to psychosocial issues in women with type 1 diabetes when transitioning into motherhood, I think this conclusion from the study really explained super well how I felt during my pregnancy journey. So women with type 1 diabetes experience a variety of psychological issues in their transition to motherhood, increased levels of anxiety, diabetes-related distress, guilt, a sense of disconnectedness from health professionals, focus on medicalization of pregnancy rather than the positive transition to motherhood, and trusting relationship with health professionals, sharing experiences with women, active social support was absolutely crucial to make through this pregnancy. So that's coming from the research, and this will be a short story of my journey of being pregnant with diabetes. I hope you don't mind sharing sharing my private pictures there, but I actually found it really good to see and remember, because first of all, I was diagnosed in 1987, and my mom was told that there's absolutely no chance she will ever have grandchildren. That type 1 diabetes is absolutely a huge risk factor, and I will probably by the age of 20, probably I'll have all those complications. So I'll be probably blind. I will have my legs amputated. That was the messaging that we had in 1987. So pregnancy was absolutely a no-go. But so many things have happened, and the pregnancy care and everything, the diabetes management has changed hugely in the last 30-something years. And I think it was really well explained as well in the slides that Fionnuala showed. And then when I was 20-something, it actually appeared that I can get pregnant. I just have to work a lot to make it happen and to have a healthy child. So first of all, I was extremely anxious to even get pregnant. And I hear it from many women with diabetes, from young adults, girls. They're extremely worried about this whole process because there's so much information, there's so much risk associated, and it's a huge pressure on you to make the pregnancy healthy, that many decide not to give birth. So I have many friends who adopted their children. They just didn't want to go through this process. So, but anyways, I decided to go through this process, very anxious. Yeah, what happened was that, I'm sure you know that in each trimester, in each week, your insulin requirements are different. So, so in the first trimester, I had loads of lows. I was continuously on a low glucose level scale, and because the recommendations are actually very strict, you have to have your glucose values very similar to a healthy person. For me, it's really lower than in my normal day-to-day. So that's why it was kind of hard to adapt to this situation. But I made it. Second trimester was fine. It was nearly like normal. It was just changing. My belly was growing. Everything went well. I had to have my, of course, checkups. I had a fantastic care in one of the maternity hospitals in Dublin. I was very happy. And then the third trimester was like, it was a nightmare. So not a nightmare in terms of in terms of my experience, but a nightmare when it comes to insulin resistance. So normally I usually take, just to explain, between 30, 40 insulin units per day, whereas in the end of my pregnancy, I used to take 150, 160 units a day. So that's the increase, that's the change. And my food was actually similar. I tried my best to try to avoid hyperglycemia, and I was absolutely very lucky to have fantastic healthcare professionals and endocrinologist who was extremely supportive, who mentioned when I was really worried, oh no, I had this hyperglycemia. He said, listen, it's all good. It's all good. Your control is magnificent. Everything will be fine. And this is probably what I needed. And I do think that many women just need this to say, listen, it will be all fine. And the last picture here on the right is I attended one event which was tackled at women with pregestational diabetes and for women with diabetes and pregnancy. It was organized in Galway by Atlantic study, and I think it was absolutely fantastic to meet other women who had similar experiences. Of course, it was pre-COVID, so we had more face-to-face events, but I found it really useful, really helpful. This kind of peer support organized by healthcare professionals and researchers was absolutely one of the benefits of my pregnancy journey. So just to sum up, why to involve pregnant women in diabetes research? First of all, I do think it's a very vulnerable population. I think women with pregestational diabetes and gestational diabetes should be prioritized in any policy making decisions, because it's not only about them, it's about humans who are going to be born very soon. And I think it's extremely important, and that's why the more focus we have on it from the research perspective as well, it's absolutely very important. Then, because it's vulnerable population, the loneliness, the shock, the huge pressure, the stigma, the blame, there is a lot around that, but the mental health isn't very often supported when it comes to these groups. So I would really love to see more research focusing on this aspect and more interventions. Then understanding what is happening with your body and how to make pregnancy safer and better, it's absolutely crucial. And through research and through appropriate communication, knowledge translation, you can make your experience better and easier. You can get better support, you can get better understanding of what is happening. And this is essential for any women, whether it's type 1 diabetes, whether it's type 2, or whether it's gestational diabetes. Then, of course, the opportunity of peer support, to meet other women, collaboration and partnerships with healthcare professionals, as Michelle mentioned earlier, that's absolutely the huge benefit of involving women in research. And you have more interactions with healthcare professionals who are usually very motivated and who are very dedicated to the topic, which is also a benefit. And then for healthcare professionals, I do think it's absolutely essential, and Michelle explained it super well, hearing from those affected, hearing about the experience, it really makes research more valid. It makes it more relevant and accurate, and it really improves the quality of the research itself and collaboration with your researchers. And just to mention the Breakfast Club comic, I think it's wonderful. It's absolutely fantastic, and it's great that such an initiative was done and conducted here in Ireland. I also wanted to mention, Elisa, that all these quotes that you mentioned, they are covering what I just said. So stigma, the self-blame, all these psychological aspects that women experience, and they just sometimes want to hear, listen, you're not alone, we are here with you, we are here to support you, and that's probably the biggest aim of involving women in research. So this is it from me. Happy to answer any questions, but I'm sure we'll have a common discussion later.
Thank you. Thank you so much, Kate. And thank you for being so open, sharing your story as well. I think, you bring a particular wisdom as a researcher, as someone who's lived through the experience of having diabetes in pregnancy, and as a psychologist as well. So thank you for that. Yes, we are moving on to the discussion section. So we have about 15 minutes now for questions. I see one question up in the Q&A tab. If anybody has any more, please do put them in. I will kick off, though, by asking Michelle. Michelle, as I say, I was really I was really pleased to hear you talk about PPI as an ethos, because I think that softens it for people. It's not like a list of instructions you have to go through. But something you did say was important to get to at the heart of that ethos is figuring out the barriers that are there for patient and public groups to be able to engage, to be able to access what you're doing. And you mentioned the one about the rugby players and the spinal injuries. Are there any other examples, or are there any bits of advice you can give people about finding out about those barriers and removing them?
Yeah, it's a great question, and I probably would divide the barriers into two main categories. The first are kind of organizational and operational. So that would be I suppose things to do with having money, because we don't want our PPI contributors to be the only people not getting paid for kind of being present or for the work that's done. Also access to training, access to supports at kind of operation organizational levels. So ways to overcome those. Most universities have a seed funding program whereby people can claim or apply for small amounts of money to get their patient and public involvement off the ground. Training is improving all the time. There's training available nationally through the PPI Ignite Network program, and there is actually a doctoral module. We're launching it actually the week after next. So hopefully PhD students coming through will have that training as part of their learning as they go through going forwards. And then I suppose it's the communication, the information sharing. So the network have worked a lot on that with the opportunities notice board and things like that. And they're probably the easier things to, kind of work around. But so the other side is, researchers' motivation, interest, confidence in getting involved, and the same for patients. So trying to match the two together. And we always say to people, look, start small, get advice. don't feel you have to do everything, you know, as well as you see other people doing it. And I don't know if you notice our logo is a little chain of people that starts with one, and, you know, people add as they go along. So start small and build up is definitely the advice for that. But do reach out and get advice, and do ask. But, you know, definitely don't, you know, aim for something like this event as your first port of call. You know, just start small and build up. And the patient organizations and charities are also fantastic in terms of, you know, some have dedicated research teams, and others are smaller, and they just have somebody who's available to give advice and link people in together. But there's plenty of barriers, but none of them, I suppose, are bigger than the benefits and the opportunities.
Great, thank you. And Fionnuala, I suppose you're someone who has created the spaces, the channels, the avenues for patients who are interested in engaging with the research. You mentioned things like the app, the steering group. Can you tell us how you went about setting those up and what those have meant for the engagement?
Yeah, well, none of these projects would have happened without focus groups. And so the focus groups were really a case of a kind of cold calling patients from each cohort, depending on what the particular research group. So if, for example, the breakfast club, when it came to, and I should mention, actually, people will wonder where the term breakfast club came from, and actually it's now kind of an outdated term, in that it's the name that we christened our gestational diabetes kind of surveillance service at a point where we were just starting to move women with gestational diabetes out of the combined obstetric endocrine clinic. We had a model of care that required, now they weren't self-monitoring at all at the time, and so there was a situation whereby, you know, the patients would attend the hospital, have a fasting blood sugar drawn. So this is, say, every 2 weeks for somebody with gestational diabetes. They would have a fasting blood sugar drawn. They would get sent down to the canteen in the Rotunda, which is famous for, actually, it's wonderful food. I should say the canteen at the Rotunda, it's the best hospital food in the country. And yet women with gestational diabetes were channeled over to a kind of corner of the canteen that had a big sign saying diabetes only, and kind of a miserable buffet of food. And there was a real kind of, it was like a queue of shame, a corner of shame for women with gestational diabetes to have to hang out and eat almost, which was almost like a supervised breakfast. After which time they went back up to the clinic, had another sugar level drawn, and might have sat for 3 or 4 hours waiting for somebody to look at their sugar results and then maybe give them the nod that they could go home and return for the same exercise 2 weeks later. And we look back on that with shame now. You know, we hang our heads in shame when we think, you know, actually, that's a dreadful way to treat pregnant women, you know. And we called it the Breakfast Club because that's effectively what it was, you know. But we would like to say that, and that's the group, that was our captive audience. And I would say that we're probably very, when you ask Claire about identifying patients and how you find them, we're very fortunate in almost all areas of pregnancy care in having a real captive audience patient population. Like, there's no time in a woman's life where she is as invested in her health as she is when she's pregnant. And I say that even of our most socially disadvantaged patients, and, you know, is that they prioritize their pregnancy outcome over all other aspects of their health. And so it's not hard to find them. You know, they are, we don't have I would like to say, actually, at the Rotunda, we have a very, very minimal issue with patients not attending for appointments. You know, they show up and by and large are incredibly informed of every aspect of their pregnancy care. So they make it their business as a general rule, they make it their business to know all about gestational diabetes, or you know, and Kate will have illustrated, she knows more about type 1 diabetes than anybody looking after her, really, you know, because that is her lived experience, you know, and it's a case of kind of respecting that. So we're very fortunate in having patients who will sign up, they'll put their hands up and readily, you know, participate or contribute to anything that will just make the landscape better for them, you know. So our focus groups were really invaluable, I would say, at just helping us design a better way for looking after this condition in a way that afforded patients the dignity that they deserve in looking after a condition that is very, very manageable, and that empowered them to kind of just take ownership of it themselves. You know, there are lots of patients who reject the diagnosis of gestational diabetes and say, actually, you know what, I don't believe in that diagnosis, you know, and fine, you know, they're entitled to do so, you know, and I think so being overly didactic or prescriptive with women about what they should and shouldn't eat and all of that actually will only risk strengthening their resolve and pushing people away. So it was all about getting patients on board, you know, and the way we're managing things now is it's not yet perfect, but we're definitely on a path to perfection in a way that we weren't a decade ago, I think.
But the key there is to actively listen to and to adapt to what you're learning as well, not just sort of listen and then go and do your own thing anyway. Thank you, Fionnuala. We have a couple of questions in that might suit Elisa and Kate, but they suit all our panelists. But there was one particularly for you, Elisa, saying that this person really liked the mention of the power of visuals as reaching wider audiences, and particularly for people who don't have English or have as a first language or have limited English. And that person is wondering if any of the projects have explored translation or alternative ways of communicating with these communities, such as maybe outreach events, liaising with embassies. And we've had another question in from Fiona as well, asking about again reaching more diverse communities, in that she finds it tends to be a narrow demographic who self-select for getting involved, middle class, highly educated in research projects, which feeds into the skewed and limited outcomes. Any thoughts on those two questions, Elisa?
Well, at the moment, we are focusing a lot on ISL and including ISL on most of our projects. When it comes to different languages, it's hard to know where to put the focus. You know, like I would love to have brought the Breakfast Club back home and show it to my mom that doesn't speak English. So I want it translated in Italian, but I mean, there's also
probably
like a focus.
Some kind of AI that can do that now. You just point your phone at it.
That's true. That's true. So like when it comes like to the hospital, the Rotunda Hospital has a list of languages when it comes to like patient information leaflets. So it has like a list of like the most spoken languages other than English. And then they were mentioning the power of visuals. So a lot of our comms project focus on that for that reason. For example, like the art exhibition, there was no word associated with, like it was just images or like video representation. But if anyone has any suggestion on how to kind of reach other like non-English speaking people.
Yes. But imagery, once it's used appropriately and correctly, and you know, with sensitivity, that is a wonderful way to get around the need for those 1,000 words in whatever language. Kate, how about you? Any thoughts on reaching those more diverse communities who are not likely themselves to come forward for whatever reason?
Yeah, that's always a question. That's always the question, how to reach those who are not as interested as we would like them to be. So yeah, I think media can play a huge role when it comes to, for example, articles in newspapers or online. So using some kind of sources that are not typical, because when you go to the hospital, this is when you expect to receive some whatever information leaflet or a comic or advice. When you are interested, you will Google your, for example, www.diabetes.ie. You'll start to look for information. But if you're not interested, and if you just feel, okay, I got it, but whatever, then you have to be reached somehow differently. So that's why any kind of awareness that comes to wider population, I think that's really important. So yeah, using media, using social media, using any opportunity for kind of marketed information, and investing in that as well. That's something that might
Yes.
be done and improve.
Absolutely.
Uptake,
Think about where people get their information and go there rather than expecting them maybe to come to you. Michelle, we have a couple more minutes. So just, you had your hand up there to make a comment.
Just briefly, I think it's a great question from both of the askers, because it's a key area that the PPI Ignite National Office is looking at. So I suppose it's, you know, sometimes it's perceived as lack of interest, but oftentimes people have a mistrust or a fear of the health system, not always because of their interaction with the health system here, but, you know, previous experiences, and that sadly have made them lose trust or feel somewhat excluded from mainstream healthcare. So it is something that is always on the table, and we're working on lots of, I suppose, ways to look at it. If you look at the opportunities notice board, you can request, you know, that people, you know, say specifically we're looking for people with different backgrounds, or maybe that aren't school leavers or whatever. So just being explicit, saying, look, these are the types of people I'd like. So making sure it's not clear. I think remembering that, you know, it shouldn't be kind of skewing or limiting outcomes, because PPI shouldn't be, you know, used to that degree in a project that it could happen. So that's a very more technical question, but, you know, obviously it does not maybe include every voice, which we know less diversity is not good for outcomes, but also universities have really good relationships. So for example, in RCSI, the REACH team led by Maria Kelly have great connections with different audiences as well. So I think it's about collaborating with the people in your organization that know how to access these people already as well.
You don't necessarily have to reinvent that wheel. No. Absolutely. We have about 1 minute left. So Fionnuala, what was your comment on that?
Just very briefly, it's just, I aligned with that actually. I think it's a super important point, is the inclusion of diverse groups. And we work in the most ethnically diverse pocket of the country, actually, in Parnell Square. There has been a tendency, and it's just a kind of historic thing for years, is that women are excluded from research if they can't read and understand the highly complex patient information leaflet that now tends to run to 20 pages potentially, and that's wrong. And so it's really super important, just at the very design stage, that we exclude women from research only on scientific grounds, and not for convenience. And we could say the same with, you know, women with diabetes, or pregnant women in general. Pregnant subjects are very frequently excluded from research, which, you know, it kind of speaks to a bit of laziness, I think, about, you know, the research and I think happily that is changing. Yeah.
Great. So thank you so much. Thank you so much to all our speakers today. We had Dr. Kate Gajewska, Elisa Belmonte, Professor Fionnuala Breathnach, and Dr. Michelle Flood, and of course to the people who work so hard to make all this happen as well. So Elisa, Zara, Holly, Mark, everybody at RCSI, Obstetrics and Gynaecology Department, and the HRB for supporting. Listen, I learned loads from you today. Thank you to the audience for being so engaged. Thank you for your questions, and yes, have a great day. Thanks everyone.
Thank you, Claire.
Thanks.